Hi guys, good evening, good evening, good evening. I hope you are able to hear me. Good. Hi Mehak, good evening. All right, so I think you all are tuned in. As we all know that we started with our esophagus series. So yesterday was our first productive topic day where we spoke about a very important and interesting topic, that is your tracheo-esophageal fistula and atresia. So we spoke about all the different varieties that you have. Hi Henry, watching from Zambia. Welcome. Thank you. Thank you for listening to us. We'll make sure this session is even more interesting today. Come up with two more disorders so that it makes it more even and understanding for us. All right, guys. So without wasting any further time, I think it's audible, it's visible, low. So let's dive down into today's topic, right? So today we'll be talking about and continuing on the same series of your esophagus, like whatever the disorders we spoke about. Today, I will introduce you another congenital disorder which is called as the dysphagia. We're talking about the dysphagia lusoria. So today, we're talking about another very interesting topic which is called as a dysphagia lusoria. Now, as you can see, there are two words here. One is dysphagia, another one is lusoria. Everybody understands the word dysphagia is basically difficulty in swallowing. It is difficulty in swallowing, right? And the word lusoria here, so this dysphagia is caused because of an abnormal vessel. So the word lusoria basically denotes it is an abnormal compression, or I can say it's an abnormal structure basically. It is an abnormal structure which is exerting pressure on the esophagus, resulting in dysphagia lusoria. Nothing spectacular about it. So dysphagia lusoria is a disease or a disorder where you have a patient having difficulty in swallowing due to an abnormal structure, and we'll try to find out what is that abnormal structure. Now, a very poor misconception that we have is about odynophagia, that is painful swallowing, right? So we're not talking about painful swallowing, we're simply talking about difficulty in swallowing, and that is going to be your dysphagia lusoria. Now, when you talk about dysphagia lusoria, what is the cause? So, why is there a dysphagia in this patient? The dysphagia here, it is because of an abnormal, it is an abnormal compression. It is an abnormal compression of the esophagus due to abnormal blood vessel. Due to an abnormal blood vessel. So when we talk about any luminal compression, no, any vessel or sorry, any structure, or talk about any bowel, any lumen, any hollow space, when it is getting compressed, you should know whether it is getting compressed from inside or outside. So this is your extra luminal compression. This is from outside. So this is going to be your extra luminal compression. So talking about here is an extra luminal compression, right? So it's an abnormal compression of the esophagus due to an abnormal blood vessel. We try to understand what is that abnormal blood vessel. So when you talk about this abnormal blood vessel, remember this abnormal blood vessel, usually it is associated with an aberrant, it is an aberrant right subclavian artery. It is an aberrant right subclavian artery. Sometimes it can be because of right-sided arch of aorta. It is an right-sided arch of aorta. Usually the arch of aorta will be on the left side. If it is an aberrant, that's the right side. Again, it is going to cause esophageal compression. And even more rare is your double arch of aorta. So these are the usual blood vessels which are known to cause esophageal compression resulting in dysphagia. Now, if you look at by incidence, the overall most common blood vessel that is going to cause this compression is going to be your aberrant right subclavian artery. Now, to understand this, let's take the normal orientation that we need to figure it out. Now, let's say this happens to be the esophagus, and this is how the esophagus is going to run, right? So this is the esophagus which is running all across here. And let's say this happens to be the esophageal external wall musculature. Just for the sake of understanding, to give you a dramatic effect, I'm just drawing the esophagus in this particular fashion. Now we know the arch of aorta, which is going to originate, is going to go override, and this is how the aorta is going to run. See, the aorta is going to override the esophagus, and this is how it is now going to go, right? So this is, we have the esophagus is going to run behind it. This is your arch of aorta, and this is the aorta that is going to travel. Now we all know that the three blood vessels which are going to originate from each of these sites. So the first one is going to be your brachiocephalic artery. From the brachiocephalic artery, you have the right subclavian artery as well as the right common carotid. This is the normal orientation. This happens to be your left common carotid. Another one is going to be the left subclavian artery, right? So this is our usual component that we talk about it. Just for the sake of understanding, I'll label it them. So this happens to be the arch of aorta. This happens to be the arch of aorta. This is your brachiocephalic artery. This is your brachiocephalic artery. This happens to be your right subclavian artery. This happens to be your right common carotid, right? This, on the other hand, is going to be your left common carotid, and this is going to be your left subclavian artery. This is going to be your left subclavian artery. Nothing spectacular about it. There's nothing new that we have learned. This is what we've been talking since the day we started learning. Let it be, our thyroid or any other disorders that we have spoken. Everywhere else, we had this representation. So this stands valid. There is nothing spectacular about it. This is normal, right? Now, this is what we call it as the normal representation. This is what we call it as normal representation. So this is how a normal representation would look like. When we talk about an aberrant right subclavian artery, what is going to happen? We're going to put same thing. I'm not going to change anything. You have the esophagus. Again, you'll notice the esophagus is going to run as it is running. Nobody is going to touch the esophagus. So this is the esophageal wall. Let's say this is the musculature that we are going to show it across. Just to give you a bit of dramatic effect, you have the same component. The arch of aorta is going to override from here. It is going to run across here, and nothing spectacular about it. So we have changed it, not even a single bit. Now, what we're going to tell you is, as I told you, there are three takeoffs that are going to happen. The first takeoff is here, the second takeoff is here, the third takeoff is here. Now, in an aberrant right subclavian artery, you will notice directly the common carotid is going to originate from here. There's another common carotid which is going to originate from here. This is your left subclavian artery. Nothing spectacular. So what is going to happen? The aberrant right subclavian artery is going to arrive just next to the left subclavian artery. Now, as it originates, it is now going to take a turn like this. Now, as it turns, it is now going to go, travel behind these blood vessels, travel behind the esophagus. It is encircling the esophagus, now coming and supplying onto the right side, right? So if you look at the entire path, this is the entire path of the aberrant right subclavian artery. Aberrant because it is having an abnormal origin. You say it is going behind the esophagus, now coming and supplying onto the right side. And this is what we call it as the aberrant right subclavian artery. Everything else remains the same. This is now your right common carotid. This happens to be your left common carotid. This is your left subclavian artery, and this happens to be your aberrant right subclavian. This is your aberrant right subclavian artery. Now, if you observe very carefully, see what has happened. Now, what is happening is this blood vessel which is going behind the esophagus, right? It is encircling the esophagus. Now, as the esophagus is getting encircled, right? This is the esophageal lumen. As you can see, the esophagus is getting encircled. If you look at the cross section between the aortic arch and the right subclavian artery, you see the esophagus is getting compressed, right? You see the esophagus, esophagus is getting compressed, right? Raghavendra sir, notes not been uploaded regularly. Beta, we are uploading the notes on a daily basis. If you are not able to find, I've told you before also, Uh, if you're not able to get it on the PW channel, you'll get it on my channel, that is the surgery guide. If you're not able to find the notes on the PW channel, or the team is, usually they're very punctual, they will post it on time. Just in case it doesn't happen, alternate is the Telegram channel that I have. It is the surgery guy by my name, that is Dr. Sandeep Seeram Reddy. Just you need to find out this. So this is there on the Telegram, this is there on the Instagram also. So both the Telegram as well as the Instagram ID is going to be the surgery guide, right? Just if you're not able to locate the notes on our main PW channel, you can get the notes from here. I'll try to put the QR code at the end so that you can scan it also, but this is where you will find notes, and we upload on the same day, right? Once the lecture is done, we'll put the notes down there for you to go just have a quick recap on the same context. Okay? Now, coming back here, as I told you, if you look at the cross section, you now see the esophagus is getting compressed between the aberrant right subclavian artery as well as that of your arch of aorta. So all that you do is, let's say if I take the cross section from here, let's take the cross section from here, and then I'm going to just blow it out of the proportion, right? I'm taking a cross section here, and we will blow this cross section out of the proportion to see what is happening, right? So we take this out, right, and then we see what is happening. You will notice that if this is the representation of the esophagus, right? Now this is the esophagus lumen that you have. This is the inner lumen that you have in the esophagus, right? Now when you look at the anterior one, the anterior surface, you have the arch of aorta, which is going to be present here. This is the arch of aorta, which is on the anterior surface. Posteriorly, you see the aberrant right subclavian artery, right? So if you look at the entire divisional status, if I just divide this esophagus dead in the center, if I divide the esophagus dead in the center, I said this is the anterior half, this is the posterior half. Anteriorly, you see the arch of aorta is here. Anteriorly, you can see this is the arch of aorta, and posteriorly, you can see this is your aberrant right subclavian artery. Now, between the aberrant right subclavian artery, and the arch of aorta, your esophagus is getting sandwiched. Now, if the esophagus is getting sandwiched, obviously it will have dysphagia. But a very interesting thing is, see, this is a congenital anomaly. It is during the birth it is going to happen. But the patient is not symptomatic at birth. A patient will only become symptomatic in later part of the life. So when you talk about it, you will understand that this phenomena is going to kick off, right? So I just quickly recap it again. When you talk about your dysphagia lusoria, it is difficulty in swallowing because of an abnormal vessel. And that abnormal vessel is mostly your aberrant right subclavian artery. What is an aberrant right subclavian artery? The takeoff is abnormal. Where is the takeoff? It is just next to the left subclavian artery, coming from here, goes behind the esophagus, encircles the esophagus, and then comes. Now the whole problem here is, as the right subclavian artery is aberrant, it is going by its own way, but problem is it is now encircling the esophagus. Now it is basically holding the esophagus like this, and anteriorly it is aorta. So it is like this, it is getting compressed. You can see in my biceps if I put it across here. So this is the aorta, this is your aberrant right subclavian artery, this is the esophagus, and it is getting compressed. Now as it is getting compressed, obviously the esophageal, it's just a muscular tube, no. So that tube is going to get compressed and cause dysphagia. But again, an interesting thing, as a note point, I want you to think, as a, I would not talk about any topic if there is no concept in it. I want you to understand each and every single thing to the deepest possible way. Now, what is the note point here is dysphagia lusoria is a congenital disorder. It is a congenital disorder, but symptoms associated with it usually presents in later part of the life, in the later part of. Now the question is, why is that so? It's present since birth, but the patient is not symptomatic since birth. ऐसा क्या हुआ कि the patient is not symptomatic since birth? See, again, when you look at the whole concept, this is what you need to remember. at birth it is like this, esophagus is there, the both arrangement is there, it is not really compressing the esophagus, it is just encircling it. Now imagine when the patient becomes usually above 40 years, right? So when the age is above 40 years, or I can say to the fifth decade, that is 50 years. Now these are the patients who are also at increased risk for aneurysm. They also increase risk for aneurysm, and that aneurysm can also occur in this aberrant right subclavian artery. Now the problem is, if it is going to have an aneurysm, what is going to happen? In a normal representation, this is how we have depicted the esophagus. Anteriorly, I said this is the arch of aorta, which is going to be here, and posteriorly you have the aberrant right subclavian artery. This is what we've been telling across it. Okay? So this is the anterior half, this is the posterior half. This is your, I say, aberrant right subclavian artery. We say right subclavian artery, but this is aberrant, so I'm just going to put A here. Now this is the arch of aorta. This is the arch of aorta, and this is our normal representation. Now, after the age, let's say when age is above 40 or 50, what is going to happen? These patients might also develop aneurysm. Now, that aneurysm, usually you know it is the abdominal aorta. It can also involve the thoracic aorta or the ascending or the descending thoracic aorta or the right subclavian artery. Let's say there is this aneurysm, right? Now, because of aneurysm, what is going to happen? Now, you say this, either the arch of aorta is going to enlarge, either the arch of aorta is going to enlarge, or this aberrant right subclavian artery, any of that aneurysm is now going to enlarge. Now, once these blood vessels are going to have aneurysm, obviously there will be increase in pressure. Now, if the pressure in the blood vessel is going to increase, what is going to happen? It is now going to compress the esophagus. Now, if the esophagus is getting compressed, now is where the patient is going to become symptomatic. So, as I told you in a very conceptual manner, that even though this is a congenital disorder, the patient will not present with symptoms at birth or during the early phase of life. They present to you at a later phase of life, again with the symptoms of compression, but that is when these blood vessels enlarge, and these enlarge secondary to aneurysm. So usually symptoms in dysphagia lusoria, usually symptoms in dysphagia lusoria is due to, it is due to vascular aneurysm causing esophageal, causing an esophageal compression. That's the basic concept that you need to understand. Now let's understand that how would a patient present to us, right? Now let's try to understand that how would a patient of, let's say, 40 to 50-year-old man will present to us, right? So we'll talk about the clinical presentation of dysphagia lusoria, right? So talk about how will the patient present to you. So talk about the clinical features associated with dysphagia, lusoria, right? So when talk about the clinical features associated with dysphagia lusoria, obviously the esophagus is getting compressed. So the first and the foremost symptom, the patient will present to you with dysphagia. Patient will present to you with dysphagia. Now here's the important concept. Any patient who comes to you with the symptoms of dysphagia, you need to have to ask a standard question, right? This is what I followed throughout my practice. This is how I followed to take the history from my patients during the day of residency till today, and it validates very every single point that you need to know from your patient. So whenever a patient comes with dysphagia, your standard set of questions. The question number one is dysphagia for solids or liquids? Is it for solids, or is it for liquids, or is it for both solids and liquids, right? So the first part of the question will ask whether the patient is having dysphagia for solids, whether it is for liquids, or is it for both solids as well as liquids. The second question that I'll ask you is, when the patient says the dysphagia is for both solids and liquids, then I'll ask, is dysphagia is more for, is it more for solids? Is it more for solids? Is it more for liquids? or is it equal for both? Is it equal for both? That means it does not differentiate between solids and liquids. The third and the most important will give you a clue towards the diagnosis. Is it a progressive? Is it a progressive or a non-progressive dysphagia? Or a non-progressive dysphagia, right? So you'll ask whether it is a progressive or a non-progressive dysphagia. So every single time you come across a patient who complains about dysphagia, if the presenting complaint itself is dysphagia, patient says I have difficulty in swallowing, you ask these three questions. Dysphagia is for solids, liquids, or both. If they say both, dysphagia is more for solids or more for liquids or equally present. And the third, is it progressive or non-progressive dysphagia? Now, the usual question is, when I say is it progressive or non-progressive, how do you know whether the dysphagia is progressing, right? You need to have a standard set of symptoms, or as a standard set of progression to call it as increasing, right? How do you do that? Now, in order to evaluate whether dysphagia is progressive or not, we have something called as grades of dysphagia. To talk about the grades of dysphagia, we talk about the grades of dysphagia to know whether it is a progressive or a non-progressive dysphagia. Whether it is a progressive or a non-progressive, right? Now, in the grades of dysphagia, the first grade or the grade 1, it is described as patient says, I am able to eat normally. That means I'm able to eat solids, I'm able to eat liquids, and there's no problem, but there's not that ease. I'm able to swallow, there's no difficulty as such, but that ease of swallowing is not just, there's some amount of discomfort, or may not have that discomfort also. It is called as grade 1 dysphagia. Now, grade 2 dysphagia patient says, sir, every time now I take a bite, in order to gulp that bite, I need some amount of liquids. I need to soften it, otherwise it is not going down. So there's some sort of an obstruction which is not allowing the solids to pass. So grade 2 dysphagia is patient requires liquid to swallow. The patient requires liquid to swallow. He says, I cannot eat solid feeds. I need to keep sipping, right? So nowadays, what I do is I club my evening hours together, right? That means whenever I'm eating, obviously I'm eating food, and in order to gulp that, I have to drink. And I'm tired drinking water, so I switch it to the best form of liquid that is available. I know you know it. Intelligent person just needs a guess. So he now has this long, tall glass, and now he's sipping and eating and he's enjoying his life. So he's no complaints as such. So इसी को बोलते हैं ना कि आपदा में भी देख लो अपना बेस्ट वर्जन क्या है, ये पेशेंट वही कर रहा है कि even he is having difficulty in swallowing, he fails to recognize it. He takes that as an opportunity, and now he has a reason that he's not able to swallow. He's sticking it to some liquids. Now, grade 3 patient who says they are the sad ones, right? Now they are not able to eat solid feeds at all, and that liquid work is not happening much. He says, now sir, it is becoming very difficult. I have to eat my baby's food. I take that baby food, mix it in water, make it a paste, and this is what my daily feed is. And he is very, very frustrated. So grade 3 patients, they are only able to swallow semi-solid feed. They're only able to swallow the semi-solid foods, right? So that is a grade 3. Now, grade 4 patient says, so nowadays I'm not able to eat my baby's food. I said, what are you doing it? So now I can only drink, right? But then suddenly when he says no, he has a grin on his face. He says, sir, because I'm only able to take liquid feeds, I do not have any ability to take any solids or semi-solids. I'm taking the best form of liquid that is available, and that is what that is what is keeping me alive. So he's going to be pretty happy about it. So grade 4 patient says that I'm only able to take liquids. Only able to take liquids, right? Grade 1 says I'm able to eat normally. Grade 2 says, sir, I need to sip something, otherwise it is not going. Grade 3 says I'm eating my baby food because it is semi-solid. Grade 4 says I'm not able to take my baby food also, I'm only drinking. That is the best form that he can do. Grade 5 is even unhappy, says now I'm not able to drink also. So patient is now able to swallow only saliva, right? So only saliva passes. Grade 5 is only saliva passes through. And the last one is grade 6, frank obstruction, not, is extremely sad, right? So this is how you know the patient is having different grades of dysphagia. Satyam, I'll explain you again. Now, grades of dysphagia mein kya hai? We are trying to tell you that dysphagia is progressive. That means it is becoming worse. How do you know it is getting worse? Initially, patient will say, sir, I'm able to eat normally. That means I'm able to take both solids and liquids. There's no problem at all. And if the pathology started, but the patient is not experiencing any dysphagia, but slight amount of discomfort, we call it as grade 1. Grade 2 patient बोलता है कि dysphagia is becoming worse. And how do you know it is going to grade 2? Now the patient, every time he takes a bite, that is a solid, let's say he's eating a chapati, right, or a roti, he takes it, he tries to gulp it, he's not able to swallow, so he requires some amount of liquid so that it softens it and then allows the swallow, and that is called as grade 2. Grade 3 patient says, sir, I am trying to, take that solid and then try to sip water. It is not happening. It is better I keep it very soft. He mashes his rice, he puts everything in a blender and then tries to eat it with a spoon, and that gulps it. So grade 3, only semi-solid food is able to swallow. Now grade 4, not even semi-solid food, only liquids are allowed. And grade 5, not even liquid is going, only saliva is able to swallow. Grade 6, not even saliva. Now, if you want to understand the intensity of what we're trying to explain, now imagine that this is the esophagus. Imagine this is the esophagus which is present, right? Initially, when the pathology is going to start, let's say the pathology is only limited to the wall. Obviously, it will not cause any significant problem. I'll say it is grade 1. Now, let's say the pathology slightly increased in size, right? Now, this is where it is obliterating the lumen with a significant amount. So here, in order to swallow, it will require some amount of liquid. So it is grade 2. Now, in grade 3, imagine it becomes even bigger. Now, if it is becoming even bigger, that means it is obliterating the lumen even more. Only liquids will be able to pass through. This is a depiction of grade 3, right? So grade 3 is going to be semi-solids, right? Now, grade 4 is going to be even a worse version of it. So you see, this is how a grade 4 would look like. There's a very little passage for only liquids to pass through. This is grade 4. And if there is even more obliterative space, if it is like this is what we call it as grade 5, where only saliva is able to go. And if it is a frank obstruction, if the whole lumen is getting obliterated, this is what we call it as grade 6. So you can see in grade 1, everything will pass because lumen is not significantly, moving on. Grade 2, some obstruction is there. Grade 3 more, grade 4 even more, grade 5, grade 6. But how do you know it is happening? It is by this interpretation, right? So you see that grade 1 patient will be able to eat normally. Grade 2, the patient requires liquid. Grade 3, only semi-solid. Grade 4, only liquids. Grade 5, only saliva. Grade 6, not even saliva. Now, some may say, sir, if not aneurysm, even if they swallow some large masses of food, do these patients get difficult to swallow? Very unlikely, because these have already adapted since birth. Okay. Usually, it is either because of an aneurysm or the vessel is getting calcified, it is getting stiffer. So it's an age-related phenomenon, because whenever the vessels are in play, usually they're associated, all the vascular pathologies are usually age-related, right? So they will only see with an elder age. Aziz, happy Eid Mubarak. I wish you all the best for that. Thank you so much for wishing me back. Okay. So this is how you know that the dysphagia is now progressing, right? So this is how we say the different grades of dysphagia. So grades of dysphagia basically tells you that if a grade 1 dysphagia patient is now moving to grade 2, it is progressive. Grade 2 is becoming grade 3, it is progressive. So as the patient complains and you see the list of complaints, if they only become worse, that means the dysphagia is progressive. Now, what is progressive? You can see the mass is increasing. So usually progressive dysphasias are associated with neoplasia. As simple as that. Okay. Any growth which is obliterating the lumen on a progressive manner will cause the lumen to get obliterated in a progressive manner, and that luminal obstructor which is progressive will result in progressive dysphagia. Nothing spectacular about it. Clear? No. Okay. I hope that makes sense. And since the right subclavian artery is passing at a larger distance, we get much less blood pressure in the right arm. But of pressure, usually it is not, respect of the length of the vessel. As long as the flow is maintained, the pressures are maintained. You can have some amount of differential pressures, but not very, prominent about it. Clear? So I hope everybody is clear with the grades of dysphagia. Now, in a patient of dysphagia lusoria, what will be the symptoms? The patient will present to you with dysphagia. The patient will present to you with dysphagia. Now, as I told you, 3 questions. Is it for solids, liquids, or both? Only an external compression is there, not a significant amount of compression. Dysphagia is only for solids. It is only for solids. And because it's not a progressive disorder, it will be a non-progressive dysphagia. It is a non-progressive dysphagia. So I have a patient who's having dysphagia only for solid, which is non-progressive, is the only complaint that you're going to have for this patient. As simple as that. Now, any patient of dysphagia, there are no other complaints. The patient will not have any weight loss. Patient will not give you any other associated symptoms. Only this. This is the only presenting symptom that the patient is having, and it sometimes gets irritating over a period of time. The patient says, "I am not able to handle." Let's handle from our end. Any patient who comes to you with this kind of a complaint, I would like to investigate. So, in terms of investigation, any patient of dysphagia, I would like to get a barium swallow. We call it as the contrast swallow. You can use a water soluble contrast also. You can use barium. Doesn't matter. You will use barium swallow. So when you use the barium swallow, you will notice that if this is the esophagus, I'm giving you a lateral view. The esophagus is getting compressed because of a blood vessel that is encircling it. So this is how the lumen of the esophagus would look like. And this is that aberrant subclavian artery which is encircling the esophagus and going in this particular fashion. You will notice that this is the blood vessel which is encircling the esophagus and going in this particular fashion. And this is how you will depict it across. This is how you will depict it across. So as the blood vessel is encircling, it is now compressing the esophagus, right? So when you give barium to this patient, I'm asking the patient to swallow the barium. And when you swallow the barium, this is how a barium image would look like. Because it is only going to outline the esophagus, the esophageal luminal wall remains same, and there is this kink that you're going to see. This is the only thing that you will see. When a patient is going to swallow barium, this is how the image is going to usually look like. Now this smooth filling defect where you have a nice narrowing which is there, which is also referred to as a V-shaped narrowing from outside, and this is what we call it as the victory sign. We call it as victory sign, or we simply call it as a V sign of an extra luminal compression, right? I know you want to see a real radiograph, and when you talk about a real radiograph, this is how you're going to look across here, right? So this is the same depiction that we have just mentioned that you're going to show across. But a barium, it is easily available, and again, it is quite widely used and it is radio opaque, so hence barium. Now as you can see in the barium swallow, what is happening is right in front of you, right? You see this is the esophageal lumen that is going to go across here, and you see there is this sudden kink which is present, and this sudden kink is because of this aberrant right subclavian artery which is running from here, right? So that blood vessel which is just encircling this, compressing the esophagus, this gives me an idea the patient is probably suffering from dysphagia lusoria, or else there's an external compression. Usually external compression above this area, we say usually in the context of upper thorax. So upper thoracic esophagus, it is usually a vascular anomaly. How do you confirm it? Now the other investigation that we can do, or also called as the investigation of choice, is to look at CT angiography. And when you do a CT angiography, you will get the evidence of dysphagia loop, right? So I did barium initially to see what's happening, and to conclude the diagnosis, I would go ahead with dysphagia. All right, I'll go ahead with CT angiography to confirm the diagnosis. Okay. Now, once you have confirmed the diagnosis that the patient is having dysphagia lusoria, let's go ahead and look at how could you manage this, right? So talk about the management. Now, there are a lot of different proposed managements that you have. One management is, the whole problem is, let's look at the problem. What is the problem? The problem is the esophagus, it is getting compressed. It is getting compressed by a blood vessel which is on the external surface, right? This is what we're talking about. The esophagus is compressed because of a blood vessel which is lying outside, and that's the problem. Initially, what was proposed is, let's go ahead and put a metallic stent in the esophagus and allow the esophagus to dilate, right? So these metallic stents, which are called as the self-expanding metallic stents, which are SEMS, were initially tried. So what is going to happen, as the stent is going to expand, this is going to exert pressure on the lateral wall, as it exerts pressure on the lateral wall, it is now able to create a patency in the esophageal lumen. It is going to create a patency in the esophageal lumen as it because it's a metallic stent, it expands, it pushes the vessel away. It is now going to push, because as it expands, it pushes the vessel away, hence not compressing the esophagus. If the esophagus is not compressed, when the patient is going to eat, the swallow can happen without any discomfort. Hence, this is what we call it as esophageal dilatation and stenting. Prajwal, don't worry, at the end of the discussion you will know कि कौन से disease में कौन सा investigation करना है, उसका क्या logic है. Every single thing will just run through it. Just be a little bit patient with me. I promise you that I will tell you about each individual concept. Okay. For now, when we talk about dysphagia, the first investigation that you see for a dysphagia is going to be a barium swallow. That's the end of discussion. Nothing more. Dysphagia है, barium करना है. Dysphagia है, barium करना है. Barium क्यों करना है? Because it's easy to do. Ask the patient to swallow, take a radiograph, you get an image, instant image. ठीक है? You can use other contrast water soluble like ioxols and all that. Your dinosol can be used, ioxol can be used, barium can be used. So it doesn't matter. Okay? But then some contrast imaging has to be done. Problem here is when you're doing the stenting, this is what we call it as the esophageal dilatation and stenting. This is what we call it as the esophageal dilatation and stenting. The problem here is when you do this or when you attempt to do this, you have put a stent, right? This is a 40-year-old patient. I'm expecting his life expectancy is another 40 years. This stent that is present in the esophagus is going to cause esophageal erosion. And you can't keep it for lifelong because it will cause more damage in the esophagus. And when you try to take it out, because of those erosions, there will be stricture in the esophagus, which is going to cause even more worse a problem. So dilatation and stenting is now not a popular option. It is now to go ahead and address the root cause. Now, when you look at the root cause, the whole root cause is in the blood vessel, right? But this is a self-expanding metallic stent, not mesh. Metallic stent are used. They are usually titanium metals that we are going to use it for an expanding status. Okay. Now, as I told you, this is not a popular option. What is the popular option? Now, the popular option is I am saying that there is an aberrant blood vessel. So, this is the aorta that is there. This is the aberrant takeoff that is going to happen. And let's understand this, right? So I'm saying that this is the aberrant common carotid. This is the common carotid. This is the left subclavian artery. And I'm saying this is the aberrant right subclavian artery, right? So this is your aberrant right subclavian artery. This happens to be your aberrant right subclavian artery. This is what is happening, right? The whole problem is it is now creating a compressive force on the esophagus. As we all know, the esophagus is across this area, right? So let's say this is where the esophagus is going to go across it, and it is going behind the esophagus, right? So just for the sake of understanding, this is now going behind the esophagus. This is now going behind the esophagus. So this is the takeoff that we have going to be here, right? Now the whole problem is this blood vessel is compressing the esophagus. That's the whole problem. Now the current line of management says the culprit is the vessel. Let's address the vessel. Now how do you address the vessel is if I take this abnormal origin out and re-implant it into a different vessel, I can just take off the entire vessel itself, right? So the compression will go away. Now I want you to understand this. The concept is very simple, but then again how it is implemented is quite intricate, right? Now it says that the problem is blood vessel which is compressing it. Let's block this blood vessel from here. So it says let's go and block the blood vessel from here, right? Once you have embolized the blood vessel, you will cut off the blood supply from here. As you cut off the blood supply, the blood vessel will collapse, but you have to give a new component, right? So where would you give it? Right. Now where would you give it? Let's take it here. So this is your right common carotid. This happens to be your left common carotid. This is your left subclavian artery. You have embolized it. Now what I'm going to do is, watch it. Watch it, watch it, watch it. This is going to be amazing. I will create the anastomosis here. So I will take this aberrant right subclavian artery, anastomose with the right common carotid. I will anastomose this with right common carotid. Usually we use a stent here to put between these two. This stent is usually a PTFE, that is polytetrafluoroethylene graft. So when you put the stent, now because the blood vessel is embolized here, this entire vessel is now going to collapse. Now blood vessel is embolized, there is no blood flow here. Now as there is no blood flow, obviously this entire vessel is going to collapse. If the vessel is going to collapse, if the vessel is going to be collapsed, there will be no flow at all, right? If the vessel is going to be collapsed, it is now not going to cause any compression. See, there is no blood flow. So you see the blood vessel is now getting collapsed. So this is like a single rim which is going to go across it. Now this is getting collapsed. So as the vessel is getting collapsed, it cannot cause any compression because there is no force in it. The esophagus is absolutely fine. And then you have created a new stenting here. And as you have stented it, what you have done is, now you have done using a polytetrafluoroethylene graft. I have put a stent. Between the aberrant right subclavian artery. So this is your right subclavian artery, which is aberrant. So between the aberrant right subclavian artery and your right common carotid. So what happens is the blood that is going to flow, let's take this is the representation of the blood flow. The blood that is going to flow, it is going to flow in this particular manner. Now as the blood is flowing, because this is blocked, the blood will not go. So from here the blood is now going to pump into your common carotid. From the common carotid, it will now go into the subclavian artery and it will now give the blood to subclavian. Okay. Now this is how you do the modern surgery. Like, I'm so intrigued by the whole idea of it. Now with the help of the endoluminal blocks, you have embolized the origin, right? So you're doing an endovascular embolization, right? We call it as the coil embolization. What you have done is, you have done a coil embolization of aberrant of the aberrant right subclavian artery at its origin, so that the blood does not flow. And once that happens, now I've put a graft between these two areas so that I can now allow the blood to flow. And you can usually cut off this also. Now when you embolize this, you can embolize the entire vessel to the origin, and then you can create a, or the anastomosis between, or again stenting between the right common carotid as well as the right subclavian artery. Usually this we do it from a small incision which is going to be in the supraclavicular, right? So this is the beauty of it. So the latest update, in fact, this is the first time ever I'm teaching this method in any class that I've taken, right? So usually, when we are talking about competitive exams, we do not have the leverage of doing it, right? The beauty of it, we usually tell, do a stenting, that's a temporary measure, come back and do a vascular stenting if it is severe. But I want you to understand how the whole functionality is going to. So this is the beauty of it, and this is how we do it in our style, right? So this is all in all with respect to dysphagia lusoria. Aberrant means abnormal. The word aberrant, somebody is asking what is aberrant, aberrant, bol bol thage na. The word aberrant means abnormal origin. The word aberrant basically means abnormal, right? The word aberrant means abnormal, right? So today's topic was dedicated to a disorder called as dysphagia lusoria. In the dysphagia lusoria, this is what the whole concept was, and this is what is happening. So we understood it is because of an abnormal blood vessel. Usually it can be of three varieties: an aberrant right subclavian artery, a right side arch of aorta, or a double arch of aorta. we try to understand that how this right-sided or aberrant right subclavian artery encircles the esophagus. Usually does not cause any problem, but when it is going to become age-related phenomena where the patient is having either an aneurysm or a calcified blood vessel, right? So usually it is because of a vascular aneurysm, or it can be because of a vascular calcification that is now compressing the esophagus. Patient presents with dysphagia, usually non-progressive. But how do you know it is progressive or non-progressive? This is the grades that you're going to look across it. Stick this in mind every single time you answer a question on dysphagia. They will say progressive or non-progressive. But how do you know it is progressive or non-progressive? This is how you know. If a grade 1 is becoming grade 2 or a grade 2 is becoming grade 3, it is progressive. It is halted at the same grade. It is non-progressive. You look at your investigation, you evaluate it on a radiograph, confirm on a CT angio, and this is how you do your management. Is that clear? Okay. This is all that you should know in the context of dysphagia lusoria. Yeah. Right. So if you have any questions, any queries, feel free to ask. I would more than happy to answer all of them. Just throw it if you can. And obviously, right after the lecture, you'll get the notes in our Telegram group as well as in the Instagram. This is the surgery guide. Look for this on the Insta as well as Telegram. It is by my name. Just look at the name also. It is Sandeep. I'm ready. So any questions, any queries, hit it across here, right? So that's it for today, guys. Thank you so much for joining, right? So this week, this was the last session. Next week we'll meet, we'll slightly increase a little bit more onto the other spectrums of the disorder. Now, next week when we come back, we'll talk about one of the most important pediatric disorders in the esophagus. We'll talk about the foreign body. We'll talk about the accidental caustic injury. We'll talk about esophageal perforation. So the whole week will be dedicated for foreign bodies. We'll give you all the bronchoscopic videos. We'll talk about the esophageal videos. We'll talk about esophageal perforation, again a huge spectrum, and then we will hit the most important topic in the esophagus, which you'll see very common in your practice, is going to be GRD, that is your gastroesophageal reflux disease. Stay tuned to us. We will, right, why are there no such classes for first year? It is there. I think our entire MedEd platform is doing the first year series. They're doing an amazing job. Watch out for Pradeep Pawar sir, who is great at anatomy. We have the whole physiology lectures are there. We have our biochemistry also. I think the first year is running quite well, right? Right. Okay. So for any questions, any doubts, quick feedback? If no questions, thank you so much for joining. We'll see you next week.